Uh, Good afternoon, one and all. We'll start the sessions. Good afternoon, one and all, and I welcome you all in this today's webinar. I, Dr. Paras Bhura, Assistant Professor at BITS Institute of Physiotherapy, would like to welcome you all in today's webinar, that is Geriatric Rehabilitation, Principal, Opportunity, and the Challenges. You know that as the age progresses, because of aging, there are lots of changing in every system of your body, and that is why geriatric people require special attention and gentle care to continue leading a balanced and healthy life. As a physiotherapist, it's our moral responsibility to add life in their years. Geriatric care aims to promote health by preventing and treating disease and disability in older adults. I am pleased to introduce today's speaker and my senior friend, Dr. Nikunj Chavda, sir. He is presently working as a director, KADJI Care and Rehab Private Limited. He is also the president in Jingo Foundation, a registered charity NGO functioning in the Vadodara. Also, he is the chairman in the Mad Talk India, an event for the awareness of healthcare in public. He has done his bachelor degree from India's first degree college in physiotherapy, that is Government Physiotherapy College, MS University, Vadodara, in 2007. He has done his post-graduation course in exercise science from world-famous Griffith University, Australia. He has more than 10 years of professional experience in geriatric rehabilitation. He is also the member of Association of Senior Living India, that is ASLI, member of Australian Red Cross Society, member of Indian Association of Palliative Care, and many more. He was awarded with the Community Service Recognition Award, NRI Setu Ratna Award, and Best Rehabilitation in Gujarat many times by Dr. Harshvardhan Sir, India. Before starting the session, I would like all the participants to mute their microphone and don't share their screen during the live presentation to avoid disturbance. I will be having and we will be having the live question answer session at the end of our session, this webinar. So if you have any doubts, please type them in the message chat box in the Google Meet. So at the end, we'll discuss in the during the live question answer session. And if you miss anything during these presentations or webinar, don't worry. We will be keeping this recording on our Institute YouTube channel. Now, without wasting a time, I will like to request Dr. Nikunj sir to start with the session. Over to you, Nikunj sir.
Thank you so much, Dr. Paras. I hope my voice is audible to everyone.
Yes, sir, it is audible.
Thank you. Thank you for the gracious introduction. We are going to talk a very sensitive subject today, geriatric rehabilitation. I'm going to cover a very basic content as of today, since it's a very vast subject, but would certainly like to bring attention to all of you to a few principles, few tips, the challenges and opportunities that you may have in this particular field. To begin with, let me help you understand that aging is not a disease. So no patient will come to you saying that I am old, kindly offer me therapy. So aging is not a disease. It's a natural condition that needs to be recognized, accepted, nurtured, and nourished. So when I say recognized, this process of recognition and acceptance starts from our mid-age. So right from when we are 40s or in 50s, we have to start recognizing that a day will come when our cells are going to get degenerated in all the systems. And on that time, we have to make sure that we don't underestimate or overestimate our bodily mechanism. So we have to recognize, accept, nurture, and nourish the aging process. Few terminologies, aging and active aging are very known, but let me bring some attention to these two particular words, the gerontology and geriatrics. Gerontology is kind of an umbrella. So this gerontology subject covers multiple aspects of aging, that is health, social, economic, behavioral, environment, and so on. However, the health is taken out of the gerontology and is termed as the geriatrics. So anyone and everyone can study gerontology, but only few, those who are medically or paramedically trained, can study the geriatrics. So when we say geriatrics, it is purely a rehabilitative, clinical, psychological, psychosocial, and preventive aspect of illness. This does not cover the social, economic, and environmental aspect of the aging. So as I said, gerontology can be studied by anyone, but geriatrics, only the medicos and paramedicos can be taken care by. There are three forms of aging. One is unwanted aging, right? So this aging usually comes either with a disease or disability. Okay? And let me tell you, most of the part starts from your 50s. Okay? The chronic disorder, the metabolic disorder, this does not start, or in all the cases, when you turn 70. Probably starts when you are 50. So that can be prevented. Usual aging is an absence of pathology, but presence of declining function. So you may not have any disease, right? But you might feel weak. Your muscles are not that strained, right? You will have limitations in all the functions, or most of the functions for that sake. And the ideal aging is an aging when there is no pathology and there is no functional loss. You can do most of the activities during this particular frame of time. That is, while if you are ideally aging yourself. Few numbers, as per United Nations, 60 years is a cutoff age to label us as an aged person. But as per WHO, the cutoff year is 65 years for the developed countries. However, for India, it is still 60 years. Few other terminologies that are used by the developed countries and not by the India is up to 75 years, they consider young old. 75 to 85 years, they consider old, and 85 plus, they're considered very old. Now, these three terminologies are mentioned a lot in the scriptures that are presented by United Nations or WHO. But when it comes to India, because the life expectancy compared to Western countries is less, right? So for male in India, it's 66 years, and female tend to live 3 more years compared to male. So it's 69 years. Therefore, these three terminologies of very old or young old, very old are not applicable in most of the cases in India. Challenges as a rehabilitation professionals. So I have divided this in 4 sections: physical, social, psychological, and economical. There are various systems that get degenerated, and mostly it gets affected at your visual level. So 88% of the geriatric community will complain of visual loss or some visual compromise. Well, if you see the second last of the histogram says locomotor system disorder. So 40% of the elderly, they do have some sort of impairment or limitations in mobility. And that's where we as a physiotherapist can play a huge role. The other are neurological, 18.7%, cardiovascular, respiratory, skin conditions. GI tract, although it says only 9%, but after 75, the biggest problem is constipation. So that if you consider that can go into double digit. The psychiatric complaints, 8.5%, and hearing loss is 8.2%. The psychological challenges, these are the main challenges we as a therapist or a service provider face in our both OPD and IPDs. The emotional disturbances, right? Now, this is the biggest challenge that we face while communicating with elder, communicating their need, their desire, their likes and dislikes. let's say, for example, if we ask them, what do you like the most, right? Or what activity you like the most? So it's possible that they might, let's say, the cricket was his or her favorite game, right? But today, because of the disability, he may not be able to play it, right? Or consider any activity the favorite activity. And the moment you ask the question, the person connects it with the memory. And that's where either they start crying, they become depressed. So that emotional disturbances comes into the picture. So it's very important what kind of questions do we ask, under what circumstances. Loneliness is both psychological as well as social aspect. You will see this loneliness in the social factor as well. But when we consider loneliness as a psychological problem, this is more to do with the neurotransmitter issues. So even if you are surrounded by the family, you feel lonely. Right? So that's actually psychostructural problem. But when you talk loneliness in social issues, that actually is when you don't have anybody around you to talk about anything, right? The neglect is very common factor. As per the HelpAge India survey, it says that 64% of the urban elder people, they have expressed the neglect and unwanted feelings. Anxiety, depression, suicidal tendencies, these are also very common psychological issues. Impaired memory and rigid outlook toward any new learning. The social aspect of challenges for us is loneliness. As I said, when loneliness is termed in social, it is not same as psychological. Social isolation usually is an act of a voluntary activity kind of thing. So one starts himself or herself isolating from the social norms, culture, the programs, the activity, and that's where the social isolation starts happening. Most of the time it happens post-retirement. So we call it PR3+. That means post-retirement after 3 years. Rapid disintegration from family. So, if you ask your dada or dadi, they will tell you that there were 8 or 9 or 10 brothers, which is not the case now. But the reason for the huge family, one of the reason, the non-medical reason, would be an agricultural lifestyle. There used to be a piece of land and everyone were part of it, right? So we became from agriculture to non-agricultural modern, the life cycle has changed. So the disintegration of family has started. Changing in social context here. This actually can also be felt right now. So you can see that, or just give 5 minutes of thoughts to yourself. Remember those friends that were there in your primary school, or those in the secondary school, or those in your college time. So that social context here eventually diminishes. Right? And otherwise also it's not easy to keep that context here so intact. But those who can successfully do it, they don't go through this problem. Bereavement is one of the biggest issue that you see it in older people. And one of the study done in United States says that the most of the fall in the bathroom happens within 4 weeks of bereavement. That is, if there is a couple, elder couple, and a husband has passed away. In such case, within 1 month of the passing of husband, the wife either gets fall or some sort of impairments, either neurological impairment or orthopedic or otherwise. Disengagement from social cultural activities is also the biggest challenge. Change in attitude of communities towards elder, inability to adapt with changing environment. Financial aspects, quite common in female because their longevity is a bit higher. So a male partner passes away, that also brings a lot of financial problems to them. Self-employed people, of course, after retirement, they don't have any source of income, and unmanaged finances in mid-age. The opportunities lies a lot. Would like you to pay attention on this. This is the small GIF, which shows the graph of population from 2015 to 2050. So that is 35 years of duration. If you see, the gray color is the population of 60 plus people will be less than 10%. The sky blue is 10 to 30%, and navy blue countries are those countries in which the population is plus 2%. So in 2015, the only country which was navy blue was Japan. But if you see by 2050, 1/3 of the world is 30% plus. Right? So India by 2050 is going to be between 10 to 30%. We expect it to be 20 or 18% population of 60 plus. In this particular animation, it says the time for percentage of population over 60 to double. Right? So in India, if you see, the arrow is too steep. Right? So from 2020 to 2055, the population will be double. So today is 30 million. In 35 years, it is going to be 40 million. So people on an average are started living 20 years longer compared to what they were living 50 years ago. So of course the life expectancy was less. Multiple reasons are associated with it. Evolution of antibiotics and all medical technologies coming up. But the question remains, like, what are you going to do for your extra 20 years? Right? Are you going to travel? Are you going to spend time with family, finding a new career, or are you going to study further? Now the thing is, if you want to do anything out of these four, the primary condition is your physical and neurological properties has to be intact, right? If there is an impairment in either physical or intellectual properties of your bodily function, none of these four activity is possible, and that can create multiple side effects, multiple problems, and that's where we as a therapist, can play a big role. So this says that in 2050, 1/5 of the world population is going to be white-haired. Right. So what are the career opportunities for us? These are very standardized area of function that we can choose. Maybe retirement communities, senior resorts, senior clubs, dementia care units, palliative care centers, assisted living facilities, and care units. And number of these facilities year by year are going to increase to multiple folds. These are very generalized principles that we follow, or one should follow if you are dealing with a geriatric rehab community. So first is ascertain the existing level of functions. Right? Now, as I said, no one will come to us saying, because I have grown, I am old, offer me a therapy. That doesn't happen. So they come with some sort of comorbid condition, impairment, or functional limitations. Right? So it's very important that you assess the existing level of functions, and then based on that, you can program your rehab plan in terms of durations and activities. Determine specific goals. Now, this is the biggest challenge for us, for all the therapists. So you as a therapist will have your own goal for the particular patient, the elder patients, that you will frame after primary assessment and taking history and consulting the patients. But it's quite possible, and it does happen, that family and the patient himself will have different goals for themselves. So let's say family will have a goal that their elder patient should be able to do X activity, right? But the elder patient himself does not want to do that activity. So the goal for that, the actual end user, that is actual elder person, may be different than the family or guardians, right? And you as a therapist or we as a therapist might have different goals based on our assessment than primary guardian or, the patient, elderly, or the family member. Recognize the multiple interacting impairment. So this comprises of very comprehensive assessment that actually takes the data of each and every system functionally and also structurally. It is highly advisable. All the system must be checked, and if needed, a physician must be consulted, must be interacted and communicated in order to frame a rehab program. For example, let's say somebody has left ventricular ejection fraction only 15%, right? And you don't know about it, okay? And you have started our program, the endurance training at let's say 70% of VO2 max or 50% of the heart rate max. What happens if you try to achieve that intensity of endurance activity? The heart of that person is not capable to deliver that much of oxygen to the requiring muscles. So the point is, three important system you must check is: first is cardiovascular, second is respiratory, and third is neurological. Without these three comprehensive assessment, it's highly risky to frame any rehab program for any elderly. Emphasize on functional achievement instead of cure. So I believe one must understand the differences between cure, treatment, and management. Right? Here, as a therapist, we are not there, or I never plan to bring cure, or sometimes most of the time it's not even possible. So, but what is possible is to bring functional achievements. Right? What do the person want to do, and at what level we can achieve the person's goals. Right? Avoid immobilization wherever possible. Immobilization brings the vascular reconstruction because the muscle tone is always less in elderly. So unless and until prescribed or suggested by orthopedic surgeon because of the fracture, this principle should be always taken care of. Devise a task-specific program, as I said earlier. Encourage socialization stimulation. So try to keep the favorite families, right? So the word favorite is very important here. Most of the cases, there is always satis kakada between the elder person and the person who comes along with them. So don't use those stimulants which are irritant to these elder persons, right? Stimulants can be a television with the videos of small kids, can be videos of pets, or can be somebody who is very jolly and entertaining in your particular setup. So the stimulants actually helps to encourage the participation of the elder person into a rehab program. Minimize medication. This principle is not in our hand. A physician who already had consulted patient, he can always be approached, or he must be approached in order to reduce medications. Why and how, it's a whole subject of a discussion that can take another 30 minutes, but will not go into this. Realize impossibility and convey it positively. I consider this as one of the most important and a challenging principle. So we as a therapist and family as a guardian, it's very important that we understand what is not going to happen. Right? And if that is not going to happen, conveying this message to the person in a positive tone is itself the combination of art and science. Of course, you need to develop a rapport before you convey this message. You need to develop a trust between yourself and a patient before you convey this positively. Right? So it takes time, um, but the messages don't give false hope because the motivation time is very less, right, in this particular community. And if you say that 4 weeks you are going to start walking, they will keep the 4 weeks on their calendar. And if that does not happen, the motivation drops dramatically. And last, improvement occurs in EMIs. It's very slow and progressive improvements that happens. It's not a magic that is going to happen. It will take time, but again, depending upon with what impairment and disability the person is coming, the rate of improvement will vary. Few tips for successful geriatric rehab program delivery. Keep the grip moderate. I usually encourage people not to grasp at all from the limb. Either use the trunk or the waist area if it's a question of the balance issues. Avoid brachial compression. Also avoid the axillary compression as well. Use back supported chair always, right? If you have a couch and if you make the person seated on the couch, it's possible that person may drop the BP, hypotension, orthostatic hypotension, or you don't know, somebody, we have seen that people may start losing glucose, hypoglycemia. Sometime it may happen that they might have seizure if it's a post-stroke cases. So keep your patients always supported on the chair, and if possible, you can also tie a small belt, of course, after consent of that particular individual. Ensure cushioning of chair and couches. This is just to prevent the pinching of the bony surfaces on the hard surfaces. Always keep guardian accompanied. This is very important. Something happens, we must be able to take help of them. They should know that what is happening with them. The thorough history helps here. If there is an issue of or the history of fall or some metabolic complications, the guardian will be a lot of help in such cases. Document vital at every position. So when I say every position, I mean to say 3 positions. One is lying, other is sitting, and third is standing. In very old community, that is people with 85 plus, right? This is one of the most dangerous issue. So we experience that in lying, the blood pressure sometimes is normal, or maybe 20/10 more, right? But the moment we make them sit, right, it drops by the rate of 20/10 per minute, right? Sometimes it's even higher than that. The moment you make them stand, the drop is even higher. Right? So it should be taken in 3 positions, and once the BP is sort of stable for them, only then the set activity should be precise or should be initiated. Use appropriate voice tone. Don't make it too horsey or too loud. Don't sort of perceive that because they are old, they are not able to hear. You have to check if the issue with hearing, try to use more of the hand gesture rather than shouting loud. Right? Use more of visual and auditory clues. Ensure maximum lighting and ventilation. This is very important. You must ensure that your therapy room has each light minimum of 22 watts. Be aware of surgical history. This especially is important if you have planned any electrical stimulation or ultrasound, or for that sense, any electrical equipments to be applied on the surface. You ensure the thorough assessment of sensory system is done. Spend maximum time on motivation than movements, because movement will not come if they are demotivated. You have to keep talking to them, try to understand what subject is the favorite subject of the individual, talk on them, try to be a good listener sometime and get out the informations, and then at the same time, simultaneously, you offer the exercises that you have planned. Ensure wheelchair safety points. When I say safety points, so when the wheelchair is stationary, the brake has to be on. I know this is very small things to sort of convey, but this can destroy the life. How does it happen? Let's say wheelchair is not locked. You are trying to shift the patient from couch to wheelchair. It's not locked. You are trying to make the person sit on the chair, and the chair rolls back, and there is fall. In patients with 70 plus year of age and comorbidity, even a low intensity fall can result straight into intertrochanteric fracture very easily, very easily. So if you are dealing with anybody who is on wheelchair, the foot should be on the foot plates. It should not be dragged. The hands should be properly placed on the arm, not hanging on the wheels. If required, the belt should be there on the trunk. And fourth and most important, the brakes should be functioning. And those who are using the chairs, they should know when to put the brakes on and when not to. So let's say the brakes is on and person is trying to drag forward. There'll be a forward tripping. So the wheelchair safety points are very important. Know which medicines an elder is taking and at what time to set the correct time for the therapy. We as a therapist, we must empower ourselves into a pharmacological effects, side effects, efficacies, use, contraindications, everything. A very small example here. The ecosprin is usually prescribed in afternoon. And let's say you have a patient, 70 plus year gentleman, coming to you in the afternoon after taking this drug. Now this drug is a blood thinner, it thins the blood. So any rapid movement or any activity which increases the heart rate, this can bring the hypertension to the patient. So if the person is on antiplatelet or blood thinner, try to set a program before the person takes these medicines. Right. Same is with there are people who takes the laxatives in the form of pills, right? And the efficacy of that is 6 hours, right? So ideally, the time for the therapy should be 6 hours post these laxatives, right? Avoid incidents of fall. This is a subject in itself. Empower and educate your caregivers as much as you can. Be patient and calm, right? This is also quite a difficult task, especially when you deal with geriatric community every day in and out. However, within certain frame of time, these traits and quality do develop by itself in the therapist. Be in touch with physician. This is also one of the important advices that I would like to give to all of you. Try to talk to them and at least let them know that I am the therapist who is going to deal with these particular patients, right? So in case if you have any doubt with pharmacological interventions or anything about the disease or impairment, you must be in touch with them. Check dehydration and constipation status before therapy execution. Dehydration is very common. Can be dealt with certain measures. For example, keep ORS ready-made solutions. Make sure that 10 minutes before you start the sessions, the person is offered maybe 50 ml of the drink, so that even if there is an issue of dehydration for next 2-3 hours, it's been taken care of. If we are dealing with patients in constipation situation, I'm 100% sure they will not be able to focus on what you are saying. The entire focus is in the middle section of the body, that is on the abdomen. So find out if there is constipation issue, a chronic constipation I'm talking of, not an acute one. Try to talk to their physician and get those issues solved before you actually try and deliver your objectives. And last, the resting duration is very important, and it should be doubled in elders compared to adults. So let's say if between two sets, I've decided to offer 2 minutes of rest to adults. For elders, it has to be 4 minutes minimum. You cannot switch sets too quickly, right? It will disturb their cardiopulmonary system. And if you feel these 20 tips and 10 principles are too much, remember BFD model. So that is belief, feeling, and desire. If you know what are the beliefs of this person, you can play around the feeling. You can actually stimulate the positive feeling and subside the negative feeling. And by that, you can achieve the desired results. So play around the belief, try to bring the positive feelings, and achieve the desired results. At the end, I would like to say that a touch and a word with love and affection has more impact than an expensive rehab machine. Thank you.
Thank you so much, sir. Thank you so much, sir, for your sharing your knowledge and experience with us. And yes, very important tips and tricks. Definitely, that will be going to helpful for all the participants, especially handling the geriatric populations. That is required. Now we'll go ahead and take some time for question answer sessions. I request all participants, if they have any question regarding this principal challenge and opportunity in the geriatric rehabilitation, you can type in the message box. So we'll discuss with the Nikunj sir. The session is open for the questions. Uh, yes, sir. We have one question from Chetna ma'am. I welcome you, Chetna ma'am. Sir, question is, any exact age bar for from where you have to try to maintain the existence level of function?
The day when we know that the aging is going to happen and it may bring a lot of challenges in our life, I think from that day onward, we should try keeping ourselves absolutely fit, not just physically, intellectually, psychologically, spiritually, and the most important, socially. Because that can happen only and only when all these fraternity are working at 100% level. When we start thinking about aging gracefully when we turn 60 or 65, it's quite possible that, one of the point I raise is that the community resistance happens, right? So for example, let's say there is a club of the people aging 30, 40 years. At the 65, you decide to join that club. There will be a resistance and you will start feeling demotivated and isolated. So I would suggest that when all these fraternities are working at 100%, you should start working towards the active aging.
Yes, sir. Thank you, sir. Now we'll wait for another minute, and almost I think you have covered the and you have given all 20 tricks and the principle now very nicely. So I don't think there will maybe the more questions. Still, we'll wait for 1 minute. If you have any questions, all the participants can type in the max chat box so we can discuss with the sir. Sir, we have questions from Dipti Padole ma'am. She's asking
Sure.
how to get mouth opening for feeding activity in geriatric with neurological condition. Can any physiotherapy technique be useful in that?
Right. So if the mouth opening component is a problem, then I would do two things. We'll definitely check the TM joint function and also the neuromuscular aspect of the facial muscles. Depending on where the limitations are, we can think of the PT techniques. But once again, we have to see the functional aspect of mouth opening, right? Let's say if the person is beyond young old, that is above 75 years, and he cannot, it's a 0% opening, and then it's a different issue. But let's say if he can open even 3 centimeters or less than 3 centimeters and the spoon can get in, I would not try to do it beyond that. But once again, it's a matter of assessment of TM joint and the neuromuscular assessment of the facial muscles. Okay. She also tried to say to win a Riles tube, right?
Yes, sir.
So with the Riles tube, our perception and experience with the Riles tube is that this is one of the most important aspect of nutrition, right? However, when RT is on, the family feels that the person is on tube feeding. But let me tell you, in the comorbid condition and in severe functional impairment, RT is the only tool which ensures the nutrition that we want to offer to the person, right? If RT is removed within 3-4 days, we see the person goes into dehydration that can lead to issues such as UTI or pneumonia, or maybe in certain cases the aspiration leading to aspiration pneumonia. So if RT is there, make sure that the person is on RT till the 100% swallowing is achieved, not even 70 or 80% of the swallowing is there.
Yes. Thank you, sir.
Sure.
I hope we have covered all the questions, and now we're going towards the vote of thanks. On behalf of entire BITS Institute of Physiotherapy and BITSphysio campus, it's my privilege to propose vote of thanks to all the participants and who helped us during this webinar and for the resounding success. First, I would like to propose vote of thanks to our distinguished speaker, Dr. Nikunj Chavda, sir, for gracing today's webinar. Thank you so much, sir. Session was very interesting and meaningful, and definitely all the principal tricks and tips will be helpful for the geriatric populations. We can handle with the, care. Sir, you can, if you want to say something, you can say. After that, we'll.
Sure.
Yes, sir.
Yeah, I would like to thank you, Dr. Paras, for letting me here and sharing the most sensitive informations. I am sure all the participants would have benefited out of it, although it was very basic informations, but I am sure it's going to help. I'm genuinely thankful, and my best wishes to the entire institutions, Honorable Jagdish Bhai Patel, Mr. Dhruv Patel, Dr. Mehul Jadhav, who is taking care of the institutions such a wonderfully, along with Dr. Sarfaraz Shah and all the faculty members of Institute of Physiotherapy who are doing wonderful and exceptional job. I'm sure with help of all of you, we are going to create an active aging, at least in India.
Yes. Thank you so much, sir. Thank you so much for your words. Now, I would like to extend my thanks to our Honorable Founder and President and Chairman Sri Jagdishbhai Patel sir, our Joint Managing Trustee Srimati Kamal J. Patel ma'am for their constant support and motivation. I extend my thanks to our Chairman Sri Dhruv Bhai J. Patel sir who allow us to organize such webinar, and my sincere gratitude to our campus director Hardi Patel ma'am for her constant support and guidance. I would like to express my profound gratitude to our principal, Dr. Mehul Jadhav sir, Vice Principal Dr. Sarfraz Nawaz sir, for their enormous cooperation and providing and creating learning opportunity for all. My sincere thanks to our respected Gade Dada for wonderful graphic designing. I would like to thank all the participants who made this event successful. I would like to extend my thanks to all senior teachers, members, Reena ma'am, Chetna ma'am, Dipti ma'am, uh, Prabha, Krupa ma'am, and other distinguished teacher across the Gujarat. Thank you so much for your participation. Last, I am happy to express my vote of thanks to our staff members who have made this webinar grand success. Thank you so much, all the team members. Thank you once again. Thank you all.
Thank you, Paras. Thank you.